In a heart under physiological load, mechanical dysfunction often precedes electrical changes. This localized section of the ventricular wall is struggling to contract, a sign that the underlying tissue is either oxygen-starved or already damaged. A radiotracer scan translates that mechanical struggle into a perfusion map. When blood flow is restricted, a cold wedge appears in the anteroseptal region, indicating a localized deficit where the tracer failed to distribute. The clinician must categorize the tissue within that dark wedge. Differentiating between permanent scar and salvageable hibernating muscle determines whether a patient undergoes an invasive revascularization procedure or continues on medical therapy alone. Resolving this clinical ambiguity requires moving past simple pattern recognition. We must deconstruct the microscopic physics of radiotracer transport and the pharmacology of coronary flow to identify what is happening at the cellular level. Coronary autoregulation is highly efficient at rest. Distal blood flow remains nearly normal until a structural blockage reaches 90%. To unmask a 50% blockage, we induce physiological stress. By forcing maximum dilation, we exhaust the heart's flow reserve, causing blood supply to collapse much earlier. We induce this state using two primary pharmacologic pathways: vasodilators like adenosine, which expand the coronary arteries, or inotropes like dobutamine, which increase the heart's workload directly. Regadenosine is the modern standard for vasodilation. As a selective A2A receptor agonist, it targets the coronary vessels specifically, avoiding the severe bronchospasms often triggered by non-selective adenosine. For patients with asthma or recent caffeine intake, which blocks adenosine receptors, we use dobutamine. This beta-1 agonist increases heart rate and contractility to mimic the demands of physical exercise. If the stress level is insufficient, blood flow remains concentrated in the digestive system. This results in the splanchnic artifact, where intense tracer activity in the liver and bowel physically obscures the inferior wall of the heart. Selecting the correct stress agent is the first step in manipulating cardiac physiology to expose underlying pathology without triggering a respiratory or mechanical complication. Certain mechanical conditions dictate which stress agent we can use. For instance, dobutamine and exercise stress are strictly contraindicated in patients with a known left bundle branch block. At elevated heart rates, an LBBB causes the septal wall to relax out of sync. This asynchrony disrupts diastolic filling, limiting blood entering the septum. On a scan, this appears as an anteroseptal perfusion defect sparing the apex, a mechanical artifact, not a vascular blockage. To avoid this false positive, LBBB patients must be tested with vasodilators. These agents check perfusion without significantly increasing the heart rate, keeping the septal relaxation rhythm stable. Recognizing the mechanical consequences of electrical rhythm faults prevents a conduction artifact from being misidentified as a critical ischemic lesion. Once the blood flow is stressed, the resulting images depend entirely on how the specific radiotracer interacts with the cell membrane. Technetium agents passively diffuse into cardiomyocytes, locking inside mitochondria for a fixed blood flow snapshot. Since they don't redistribute, imaging is delayed 90 minutes to clear background tissue. Conversely, Thallium-201 is actively pulled through the sodium-potassium pump, requiring the cell to be metabolically active. Thallium's distribution is biphasic. It enters the cell based on initial blood flow, but then it washes out and redistributes over several hours, moving back into the bloodstream and into neighboring cells. The choice between a passive tracer and an active one determines which cellular machinery we are testing and dictates the required imaging timeline. Mapped on a diagnostic grid, a healthy heart shows bright tracer uptake during both rest and stress phases. Ischemic tissue appears normal at rest, but develops a defect under stress. Dead scar tissue creates a fixed defect, showing no uptake during rest or stress. However, not every fixed defect is a scar. Stunned myocardium occurs after an acute injury. The blood flow has returned to normal, but the muscle is temporarily unable to contract. The more complex case is hibernating myocardium. Chronic low blood flow causes the tissue to power down to survive. On a technetium scan, it looks like a permanent scar because the blood flow is too low to deliver the passive tracer. The sodium-potassium pump mechanism in hibernating cells remains functional, even if the tissue isn't contracting. While passive technetium particles bounce off the membrane, the pumps slowly pull thallium inside, resolving the apparent defect over several hours. This redistribution is the definitive proof of tissue viability. It allows clinicians to distinguish between permanently dead scar and salvageable, sleeping myocardium. While perfusion scans map blood flow, MUGA scans map the blood pool itself. By tagging a patient's red blood cells with technetium-99, we can measure the volume of the heart's chambers with high precision. This makes MUGA the gold standard for calculating ejection fraction, particularly when tracking the cardiotoxic effects of chemotherapy drugs like adriamycin. Geometric accuracy is vital. In this left anterior oblique view, an enlarged left atrium can physically overlap the left ventricle. This overlap causes the scanner to miscalculate the blood volumes, resulting in a falsely low ejection fraction. PET imaging using rubidium-82 provides an alternative. Like thallium, it is a potassium analog, but its extremely short 75-second half-life requires rapid imaging and typically results in a higher level of visual noise. These specialized tools provide high-resolution data on heart function, but they require the clinician to account for specific geometric and temporal artifacts. Before diagnosing a fixed defect as scar or hibernation, we must rule out physical attenuation, external structures that block the signal before reaching the camera. In this short axis view, anterior breast tissue can block the signal, creating an artificial blind spot or false perfusion defect in the anterior wall. Similarly, a high diaphragm can attenuate the signal from the bottom, creating a false defect in the inferior wall. If a defect appears in these specific anatomical zones, we check the ECG and wall motion. If the heart is contracting normally and the electrical signal is stable, the defect is dismissed as a simple attenuation artifact. Accurate nuclear cardiology requires a rigorous, step-by-step synthesis of cellular physics, pharmacological triggers, and anatomical deduction.